Hyperprolactinemia is a condition in which the concentration of the hormone prolactin in the blood is higher than normal. Prolactin is produced by lactotroph cells in the anterior pituitary gland, a pea-sized organ that sits in a shallow depression, the sella turcica, at the base of the skull. Under ordinary circumstances, prolactin's main job is to stimulate milk production after childbirth. When prolactin levels rise in the absence of pregnancy or lactation, the body mistakenly prepares for milk synthesis, leading to a cascade of clinical signs such as galactorrhea, menstrual disturbances, and infertility. For example, a 28-year-old woman who has never been pregnant might notice a thin trickle of milky fluid from her nipples after a warm shower. This is a classic red flag for inappropriate prolactin secretion. A variety of internal and external factors can push prolactin levels upward. The most frequent organic cause is a prolactin-secreting pituitary adenoma, called a prolactinoma. Pharmacologic agents are also common culprits. Typical offenders include dopamine-blocking antipsychotics, risperidone, certain selective serotonin reuptake inhibitors, and high-dose estrogen-containing contraceptives. Endocrine disturbances such as untreated hypothyroidism raise thyrotropin-releasing hormone, which in turn stimulates prolactin release. Other triggers include chest wall irritation, recent mastectomy or severe breast trauma, chronic renal insufficiency, and physiological states like pregnancy or nursing. A practical example, a patient who begins treatment with the antipsychotic haloperidol may develop irregular periods and a noticeable milk discharge within weeks, prompting a workup for drug-related hyperprolactinemia. Lactotroph cells in the anterior pituitary continuously synthesize prolactin, but its secretion is kept in check by tonic inhibition from hypothalamic dopamine. Dopamine travels down the pituitary stalk and binds to D2 receptors on lactotrophs, effectively applying a brake that suppresses hormone release. When this brake is removed by a prolactinoma that produces its own prolactin, by medications that antagonize dopamine receptors, or by reduced thyroid hormone that indirectly lowers dopamine tone, prolactin secretion accelerates unchecked. Think of the system as a car. Dopamine is the brake pedal. When the foot is lifted, the car prolactin speeds up, flooding the bloodstream. Consequently, target tissues such as breast epithelium receive a constant stimulatory signal, leading to the clinical picture of hyperprolactinemia. Hyperprolactinemia is relatively common in reproductive-aged women, largely because menstrual and fertility disturbances prompt clinicians to check prolactin levels. Roughly 0.4 to 0.5% of the general population shows mildly elevated prolactin without obvious cause. Among women evaluated for oligomenorrhea or infertility, the prevalence rises to 1 to 2%. While men are less frequently affected, they can present with decreased libido, erectile dysfunction, or galactorrhea. Large prolactin-secreting macroadenomas are rare, affecting about 1 in 10,000 individuals, but they carry a higher risk of visual field compromise due to optic chiasm compression. The hallmark clinical manifestations stem from prolactin's role in lactation and its interaction with the hypothalamic pituitary gonadal axis. In women, the most recognizable sign is galactorrhea, spontaneous milky or serous discharge from the nipples that may occur with or without a full-month menstrual cycle. Menstrual irregularities, oligomenorrhea, amenorrhea, and infertility follow because excess prolactin suppresses gonadotropin-releasing hormone, lowering LH and FSH. Libido wanes in both sexes, and men may experience erectile dysfunction or decreased beard growth. Larger tumors can produce headaches, visual field cuts, classically bitemporal hemianopsia, and occasional nausea from raised intracranial pressure. A teenage girl who notices a single droplet of milk after a warm shower, without being pregnant or nursing, should be evaluated for hyperprolactinemia. The diagnostic workup begins with a quantitative serum prolactin assay. Values above the laboratory-specific reference range generally greater than 20 nanograms per milliliter for females and greater than 15 nanograms per milliliter for males. Prompt repeat testing after the patient has rested to exclude stress or nipple stimulation spikes. Serum thyroid stimulating hormone TSH is checked concurrently to rule out hypothyroidism, and renal function tests are performed because chronic kidney disease can falsely elevate prolactin. If persistent hyperprolactinemia is confirmed, magnetic resonance imaging MRI of the sellar region is ordered to visualize any pituitary adenoma and to assess size, invasiveness, and relationship to the optic chiasm. A formal visual field examination, automated perimetry, detects early chiasmal compression. For example, a 35-year-old woman with a prolactin level of 85 nanograms per milliliter and a normal TSH will undergo MRI, which may reveal a 6 mm microadenoma. Hyperprolactinemia can be divided into primary, idiopathic, and secondary categories. Primary forms have no identifiable cause. Many are later attributed to tiny, unsuspected microadenomas that escape routine imaging. Secondary hyperprolactinemia arises from extrinsic factors such as dopamine-blocking drugs, hypothyroidism, renal failure, or chest wall irritation. When a pituitary tumor is present, it is called a prolactinoma and is further classified by size. Microadenomas are less than 10 millimeters in maximal diameter and usually cause mild to moderate hormone excess without visual impairment. Macroadenomas are 10 millimeters or larger, may produce higher prolactin levels, and are more likely to compress the optic chiasm, leading to visual field defects. First-line therapy consists of dopamine agonist medications that restore the inhibitory brake on prolactin secretion. Cabergoline taken once or twice weekly is preferred for its high efficacy and favorable side effect profile. Bromocriptine is an alternative, but often requires multiple daily doses and can cause nausea. Within 4 to 8 weeks, most patients achieve normalization of prolactin levels, resolution of galactorrhea, and restoration of regular menses. Tumor size usually regresses, especially in microadenomas. If a patient cannot tolerate dopamine agonists due to severe side effects, surgical transphenytal resection or stereotactic radiosurgery becomes an option, though long-term remission rates are lower than pharmacologic therapy. Discontinuation of offending drugs, for example switching from a dopamine-blocking antipsychotic to a prolactin-sparing alternative, can also normalize hormone levels. Primary prevention focuses on minimizing exposure to known prolactin-raising agents. When a dopamine-blocking drug is essential, clinicians should monitor prolactin levels periodically and consider dose reduction or substitution with a prolactin-neutral alternative. Regular screening for thyroid dysfunction and prompt treatment of hypothyroidism reduce secondary prolactin elevation. Individuals with a family history of pituitary adenomas benefit from early endocrine evaluation if they develop menstrual irregularities or unexplained galactorrhea. Lifestyle measures such as avoiding chronic chest wall irritation, for example tight bra straps, and maintaining good renal health also contribute to risk reduction. When diagnosed early and managed with dopamine agonist therapy, the outlook is excellent. Most patients experience reversal of menstrual disturbances, regain fertility, and cease galactorrhea within months. Bone mineral density, often compromised by chronic hypoestrogenism, improves as estrogen levels normalize. Long-standing untreated hyperprolactinemia can lead to persistent osteopenia, infertility, and, in the case of large macroadenomas, irreversible visual field loss. However, even patients with macroadenomas achieve good control of prolactin levels in greater than 80% of cases with medication. And surgical or radiotherapeutic interventions are successful in the minority that are drug-resistant. Overall survival is not affected by the condition itself. The past decade has seen several breakthroughs that enhance diagnosis and treatment. Long-acting cabergoline formulations now allow monthly dosing, improving adherence for patients who struggle with weekly pills. Ultra-high field 3 Tesla MRI provides resolution down to 2 millimeters, enabling detection of previously occult microadenomas and facilitating precise surgical planning. Genomic studies have identified mutations in the MEN1 and IP genes that predispose individuals to prolactin-producing tumors, opening avenues for personalized medicine and targeted molecular therapies. Additionally, early-phase trials of selective D2 receptor modulators aim to reduce side effects while preserving efficacy, potentially expanding therapeutic options for patients intolerant